Good morning, everyone, and welcome to today's webinar of the Integrated Communities Care Management Learning Collaborative, Care Navigator Implementation, a Community Perspective. Just one moment while we get the slides to advance here. Bear with us. So before we begin, I'd just like to cover a quick brief logistical points. On this slide, you see a screenshot of the webinar control panel. You each have one of these, and this is your tool for participation in today's webinar. Under the header audio in your control panel, you'll see two options, telephone and mic and speakers. By default, the webinar will connect through your computer's audio. If you'd like to change this, please click on the telephone button and you will be provided with call-in information. All participants are muted in order to optimize sound quality for the duration of today's webinar. We encourage you all to post comments or raise questions using the question box in your webinar control panel at any point during today's presentation. I also want to notify participants that this webinar is being recorded and will be made available for future training purposes. Finally, we have uploaded today's slides into the webinar, so if you look in the handouts section in your control panel, you'll see the PDF there that you can download and save to your computer. So with that, it's my pleasure to introduce our first presenter, Maura Crandall, Manager of Clinical Operations at OneCare Vermont.
Hello, everybody. Good afternoon. And I just want to go over the learning objectives for today's presentation. During the presentation, each of the four Robert Wood Johnson Foundation communities will be sharing their experience in rolling out Care Navigator. They're going to go through some tips and opportunities that they can share with you. And through these presentations, we hope you can identify the steps needed to implement Care Navigator in your community, understand the user roles within the system, and have some information about the time frame of the rollout, as well as gaining information on steps that you can take now to start preparing for the Care Navigator rollout. This webinar is really an introduction to this content, and the December Learning Collaborative will go into more detail. As far as questions, please go ahead, as Erin said, type your questions in the question box at any time during the webinar, because we don't have a specific question time in the presentation. Okay. We're going ahead to the next slide. So when you look at an overview of an ACO, as with any healthcare system, the patient is at the center, and those four boxes are components of the ACO. We know that there's insurers. ACOs are also connected to state and federal healthcare reform. Patients are attributed to providers who join the ACO, and then also a wonderful part of an ACO is that we can include those continuum of care providers who don't actually have attribution, meaning the patient's connected to them, but they do see patients and affect the outcome of their care. So I bring this up because ACOs offer a different way of communicating. If these continuum care providers and medical providers are connected within the ACO, people attached to those entities can communicate about a patient within the system. And this really could be a whole hour-long topic of the ability to communicate within an ACO, so we aren't going to go there today, but I always do bring that up, that the ability to communicate in Care Navigator is because everyone who has access to Care Navigator is connected to the ACO in some way and to that patient. Therefore, they're able to communicate in the system. A part of an ACO is looking at more coordinated care. And being able to coordinate care, as we learned in the Learning Collaborative, is being able to communicate. So that is one of the goals of Care Navigator. Also, when you look at NCQA ACO accreditation standards, there is a standard about being able to communicate within the ACO system. And so that is also, we're meeting that accreditation standard by having Care Navigator as our communication tool. Now at this point, in Care Navigator, the population is only OneCare Vermont, which is 116,000 patients. That's 18% of Vermont's population. When we include CHAC and Health First, that's 29% of Vermont's population that will be in Care Navigator. As we know, the all-payer waiver was recently signed and is going to go into effect. And CMS, the goal is to have 70% of Vermont's population in an ACO by 2022 and 90% of Medicare beneficiaries in the ACO. So we're preparing for that as well in the system. So that is a little bit about the background for having Care Navigator and why the ACO is invested in that. So the next is the Care Navigator timeline. We did start working in April with Care Navigator. In May, we held the focus groups with the Robert Wood Johnson Foundation communities, incorporated the feedback, and had the initial training June 30th for the communities. And in July and August, we gave system access to the training version of the system. And September, we had our go live. And in October, we've been working with the regional teams to identify the top risk patients. In November, where we are today, we're sharing what we learned in this work with everybody here. And then in December, the community workflows will be looked at in the December Learning Collaborative session. In January, we'll be working with any interested communities who want to start using and getting trained in Care Navigator. And then for the communities that are in the next generation Medicaid program, we'll be looking at expanding the use of Care Navigator beyond the high-risk communities. And then in February, the ongoing training and engagement of care team members. So that is the anticipated timeline. In the next slide, we have a pictorial image of the 4 communities that are in the Robert Wood Johnson Foundation grant. We look at St. Albans, which has 22 users, and I'll go into a little bit detail on in the parentheses, the 7 CCSs. And so you can see the organizations within each of those communities that are involved with Care Navigator at this point. These are the ones that actually have access to the live version. It might just be 1 or 2 from that organization, but these are the organizations that have access. Bennington, 29 users, Burlington, 22, and Berlin, 17 users. And as we're working in these communities, we continually focus on what are the goals of the software. If you look at the lower left-hand corner of identifying high-risk patients, identifying care team members, care team member communication, and shared care plan development. So in Care Navigator, there are a couple different roles, and I'll go into that more on the next slide. But the Care Coordination Supervisor is the one who has lists of patients. So the more Care Coordination Supervisor roles we see in a community, the better, because those are people that can be assigning patients. So if you could go to the next slide. So in the Care Navigator, there's the role of the Care Coordinator, and this is someone who are assigned patients by the Care Coordination Supervisor. And when we say supervisor, this doesn't mean somebody who's managing people and doing their evaluations. It's someone who's looking at patient lists. Care coordinators can only view patients that they're assigned, and they can also add other care team members. And once they add other care team members, those care team members can view the patient information. These roles are based on the HIPAA minimum necessary rule, and they may be fluctuating as we roll out Care Navigator, but we did the best we could to come up with initial roles. So the care coordination supervisor views patients based on their business unit. So for example, if someone is working with NMC, they would, and their care coordination supervisor, they would be able to see all patients attributed to NMC, just like they would in their EHR. They can assign patients to care coordinators. And then there's a care coordination supervisor, One Care Vermont, and that individual can see all patients attributed to One Care. And the reason why we have this role is because, as we know, attribution and where people are attributed in their health service area is not always clean. People move around. So somebody needs to be able to look into the system and see if they're anywhere in One Care Vermont. And as we've initially seen, there are people who are actually in St. Albans but are attributed to Middlebury because they maybe were there before. So that's what that role is. Okay. So that's a little bit about the roles, and now we're going to move into the Care Navigator community implementation. And just to orient you to this pretty busy slide, the yellow boxes are steps that we are going to have the 4 communities cover within this presentation. The green boxes are where we've inserted the Care Navigator trainings that are occurring. We have regularly scheduled trainings at different levels. So that's where those would go into this process. And along the bottom, we're saying always updating stakeholders and future care team members on the progress and rollout and expansion plans. In the community collaboratives, talking about where the team is with that so that you can get input as you go along. So with each of those boxes, I'm going to go ahead and the first one that we're going to talk about is the first step of convening community leadership. And the goals are defining the core team for Care Navigator implementation and identifying a lead point person in the community. And if you could go to that next slide, we have Leslie Hendry, who's going to share tips and opportunities. And if you could just introduce and talk a little bit about your role.
Sure. So as mentioned, I'm Leslie Hendry. I am the Blueprint Project Manager for St. Albans. And to take this slide a little bit out of order, I am the lead point person in my community because it just sort of naturally happens that way. I interact with everybody pretty regularly, including One Care. So when the opportunity came up and we started talking about who can set up meetings and reach out to people, it was just easy for me to do that because those are the people I already talk to on a really regular basis. So we started by reaching out to our community leadership to talk about Care Navigator and to even get basically approval to do this. We included everybody. We included quality and data analytics from the hospital. We included the inpatient case management team, SASH, CVAA, or AgeWell now, home health and skilled nursing facilities, as well as our designated agency, which is NCSS. And we've taken the opportunity to talk about Care Navigator all the time. We had a focus group meeting. We've talked about it at our RCPC, which is our community collaborative. And people were really, really interested in doing this. So that was a relatively easy step for us. Defining the core team for implementation was a little harder. Everybody wants to be involved, so there was a little bit of judicious weeding out, and part of how it worked was really keeping everybody in the loop, even if they weren't part of making the decisions right from the get-go. We did try to include basically someone from all of those groups that I mentioned initially, and really sat down and decided how are we going to pursue this as a community and what makes the most sense, and talked through the entire process start to finish before we even jumped into it. And so what we ended up deciding was that we would take that core group, the case management, which included the ER, SASH, CVAA, home health, and NCSS, and reach out to each primary care practice and ask them to have a meeting with their IT and data person, with their business manager, with their nurse care coordinator if they have one, with their social worker. And then we all sat down in a room and said, you know, this is what this looks like. Here's the expectations as we know them right now. Are you interested in engaging in this process? the answer from everybody was yes, absolutely. And they had really great questions that even now we don't always have the answers to, and I was super impressed with the depth of how much people really wanted to know. It was mind-blowing. A lot of this actually was part of the ICCMLC. It's the same people for the most part. You know, we talk about collaborative overload, and this felt like one more thing, but it was also a really good way to re-engage the people that started out strong in the Learning Collaborative and kind of petered off as the year went on. So we were able to touch back with those people. Remember your frustrations of how we couldn't communicate, how we couldn't share these care plans, how we couldn't identify the people? Here's how we put it all together. You'll be able to upload your Camden cards and your fall risk assessments and your shared care plans, and it's all right there for you. So that was nice, and hopefully everybody will show up in December. So what else do you want me to hit on that?
No, I think that's good, and yeah,
that's how we started.
That's great, and I guess really the importance of engaging primary care in this process.
Yeah.
Because when you look at those are where the patients are attributed, and that is where the patients are seen, and where and where a lot of work can be done that can be coordinated with the continuum of care providers. So I think, Leslie, you did a lot of work in engaging primary care.
I did, and a lot of that came by anybody who was at the last in-person learning collaborative. I think I was pretty honest about the fact that if I had to do it over again, I would have approached it differently than trying to tackle it as an entire community and rather break it down by primary care practice and involve the community agencies, because it seems to be an easier way to reach out and track things. And so this really gave me the chance for my do-over.
And you did talk about visiting regularly with the primary care practices, even if they weren't in the core team, kind of letting them know what's going on so that they would stay engaged. And I think that's a really important part of the process as well.
Yeah, and we've actually tried to also continue to loop in even the groups that aren't participating, or what's the word with OneCare, affiliated?
Participated.
Yeah. Yeah. So, you know,
participants are collaborating.
Yeah, you know, VCCI doesn't use the Care Navigator at this point, but they're not excluded from the meetings for sure. So.
Well, and then having the practices that aren't in OneCare.
Yep.
And could you talk just a little bit about the integration with the current meetings that you have for the Learning Collaborative, just briefly?
Yeah, you know, it's kind of all ended up being one big muddy mess in a way. Like, there's no longer any distinction of we're doing this for our Learning Collaborative and this because of Care Navigator and this because of CHT. It's ended up being, it's a small community, everybody, it's the same people across all the meetings, and so we've sort of streamlined it and kind of combined everything into one. It's worked really well for us for the most part.
Okay. Thanks,
Leslie. Maura, I'm just going to do a quick check. Do we have Terry on the line? Terry, can you hear us? And let us know if we can hear you. So,
all right. So this is Maura speaking again. And so the next part is convening a core team with the goal of identifying the Care Navigator user roles, strategies for medical practice engagement, and the Care Navigator expansion plan for the community. And from Bennington, Terry Reinertson had some great tips and opportunities. So what they did in Bennington was identify organizations that work closest with their HSA. So SASH, Bennington Project Independence, they looked at those and came up with a phased implementation plan, which I'll share in a little bit, and identifying the Care Navigator user roles in the community, and also because they're do have care coordinators in the medical practices, letting those practices know what was going on with their plans, And the phased approach of adding teams and individuals and coming up with an expansion plan, that was their real strong point in this. And if you could just go to the next one. So that's a little hard to read, but phase one is that they really wanted the Blueprint case managers to learn the system, and as well as the dietitian and the social worker. So we've been working closely with that team on the system, to having all of them learn the system, and they've actually been doing some beta testing for us. Because we're working really closely with that team of a core group of people, we've been able to identify some changes that we needed to make within the system. So their goal is to have that team know the system, and then in phase two, they'll invite in this second wave of individuals, and then they have the phase three organizations, phase 4, and phase 5 individuals. So it seems to be working well, and they are getting to know the system, and then they can help others learn the system as well. And Terry, did you join by any chance?
I'm just checking the participant list, and Terry did let us know that she's in, but maybe she's logged in under someone else's name because I don't see her. I apologize, Terry.
So while we're waiting for Terry,
yeah.
Can I ask, because I think that Terry gives us a really good example in her diagram about how to expand out. And Leslie, going back to your community example and my understanding of it, let me check this if I'm right. You originally engage the primary care practices by going in and explaining what you've been doing around the Integrated Community Care Management Learning Collaborative and this new Care Navigator tool, and then allowed them to begin to pick the patients. That became your engagement plan. Then after that, my understanding is you then identified that the care team members that you would put in based on who was connected to each of those patients. And so as you expand out to additional practices and as you expand out to additional patients, you have a natural process for expanding your care team members. And you use kind of some of the Integrated Community Care Management Learning Collaborative processes with them, like the eco maps to identify the teams. Is that correct?
Yes, it is sort of. That's our goal.
Right. That's kind of your expansion.
That's kind of your expansion plan. What we initially did was I just grabbed the big players from the main organizations and went, bring me a list of people you want to talk about. And we locked ourselves in a room and went, okay, give me a name. And everybody in the room went, yeah, we all know them. So it was kind of an in-person eco map without a patient.
But that's how you
Is she on there?
Yes. Yeah. Yep. Absolutely.
To really look at. And I think that that's similar. I mean, Terry kind of expanding out gives you kind of ideas of how expansion plan works.
Yep.
So is Terry with us now? Terry, can you say something? No, sorry, okay. Terry. We're having trouble getting that to work. I think Terry signed in under Sandy's name, so that was part of the confusion. Okay. But we're going to go ahead and move on. Oh, hi, Terry.
Can you hear me now?
I can hear you. Great.
I can hear you guys, and I'm trying to talk, and nobody can hear me.
Do you want us to move back a slide to the, or do you want to be on the expansion plan?
Yeah, you could go back a slide, I guess.
Okay. Yeah.
So I just kind of wanted to identify how we, this is Terry Ronenson, the Community Health Team Leader for the Bennington Blueprint. And we in Bennington did not participate in the Integrated Communities Learning Collaborative because we had another pilot that we were involved with as part of Southwestern Vermont Medical Center. And it was a pilot that was with the care coordinators for the Blueprint and the hospital with the Vermont Department of Aging and Independent Living. That included the partners of the Council on Aging, the Brain Injury Association of Vermont, and the Vermont Center for Independent Living. And this was a year-long pilot that we worked very closely with these team members in basically trying to work out a kind of a care management collaborative type of system. We were able to get those players on the secure email system. They were able to attend daily huddles at the hospital. So we were able to start that communication between the hospital and the Blueprint practices and care coordinators there, and just kind of get all of that care coordination up and working. And through that, we were also able to come up with not a shared care plan, but it was a form that we came up with called a universal transfer protocol, that basically we worked to figure out what specific points the case managers in the practices and in the hospital needed to know, so that the different players on the teams could communicate back and forth, and we could do this through the secure email system. So that was one way with those players. We had a very close relationship from working with them for that pilot over the year, so they were kind of brought into our team. And then because we are, our community health team is employers of Southwestern Vermont, when we started with the Blueprint, we worked very closely with the case managers in the hospital, the SASH team, the VNA in the area, and the transitional care nurses, and worked out workflows right from the start as to how we could communicate, because we're all pretty much on that same secure email system, and we were able to get SASH on the secure email system and all the other players. So that's kind of how we identified those organizations. We already had a really close working relationship with them, so it just kind of seemed natural for them to fit into the picture. And then as far as identifying the Care Navigator user roles in the community, what we did to start, and things are kind of changing as we're rolling out and going through the different trainings, we're kind of changing things as we move along. We first started with myself as and still is, the care coordination supervisor. But actually this week in our training kind of decided that it might make more sense for the care coordinators themselves to actually be able to be the supervisors also, because then they can actually assign themselves patients when they're in the practice, because they work closely with Rona, who's our One Care Vermont clinical consultant, on their beneficiary data reports in their top 5%. And when they're looking at a patient, they want to be able to just go right into Care Navigator and be able to add that patient and start adding care team members and working with them. So that's something that we're going to look forward, moving forward into doing. As far as the medical practice engagement, because our community health team is embedded into the practices and have been since we started, it was kind of a natural flow, because the care coordinators are right there in the practice. So the medical practice has kind of been engaged from the start, because the care coordinators are working on this Care Navigator training. And then you can go on to the next slide there for so this rollout plan that we come up with is basically because of the players that we've kind of identified as the organizations that we're working closely with. Our SBMC players are on the next level to be trained, because we work very closely with the case managers, the transitional care nurses, the VNA, and then moving down the line, we just moved out a little bit more to those different players. What we decided when we first did our training, we kind of invited everybody to the training, and we had a room full of people, and it was just too much. So that's why we've cut it down into these groups, smaller groups of rolling out the plan, so that the training will be more specific to these groups. Smaller trainings seem to work better. And we've run into quite a few problems as we've been going through. I think this was our third one, Mara. Was this our third one we did this week? And each one, we're identifying different problems. So it's been a very slow process. As far as the expansion, at first I think we thought it was going to be a couple months of training, and then we would be able to move on to the second phase. But I think because we've run up with so many roadblocks, we're thinking that it may be maybe even a 6 month with the first team before we're able to roll out, because we really want that first team to feel comfortable with the use of Care Navigator before we add any other team members on. So, so that's the Bennington plan, if anybody has any questions.
So I haven't seen any questions come in yet. Just a reminder to folks, any questions that you have, you're on mute. So type your questions into the questions panel, please.
Well, thank you, Terry. Appreciate
Sure.
that. So next in that, so we talked about the blue boxes are where to insert those standardized trainings. So we're on to Care Navigator User Training 1, which is in the training version without any PHI in it. So we're at convening the core team to identify initial patients, identifying care team members, and assigning patients to the lead care coordinators. And to speak about that, we have Robin, and if you could introduce yourself and tell us about your process.
Sure. Hi, everyone. I'm Robin Skiff from the Chittenden County Health Service area, and I can tell you a little bit about sort of how we have interwoven this process into our care management collaborative teamwork, and how we're moving forward with identifying patients, team members, and lead care coordinators. So if you flip to the next screen, this is an illustration of what our Chittenden County team looks like right now, and we are identifying patients at that sort of that red circle there. This is an evolution of our integrated communities care management team. We were one of the first communities to be part of the pilot, and as the piloting and sort of learning collaborative process has evolved, this is what we have come to as our structure. And we're, you know, sort of working to weave this, because really what we're working with all together in our community is around our complex, you know, patients and people, and how do we collaborate together through this process, and how do we build on what we've already learned and the teams that are already engaged with the care management collaborative, and blend that in with Care Navigator. So we're trying to weave that into our existing process, which I think, you know, we have been fairly successful at so far. So the red circle around our participant identification team, that's where we have been talking about and identifying patients for our collaborative shared care process. And those, we have integrated identifying patients for the Care Navigator pilot into that. Because we're a large health service area, we have also identified sort of these 4 teams that you see below by region in our health service area. And we are looking, the sort of groups that are relevant today are the participant identification team and the Chittenden West team. We've chunked that down, so our team is really working with patients who are patients of practices at 2 of the attributed practices, which are the family medicine and internal medicine given Burlington, a large practice, and the pediatric practice here in Burlington, as well as our Community Health Center of Burlington and a couple of practices that have recently joined them. So we identify patients a couple of ways. So we have, for this initial subset of patients, you know, we have a report that we receive that our team reviews in advance for patients with parameters we've identified, and we also look at Care Navigator, and we review that list in advance and then get together at this participant identification meeting to talk about those folks, identify who is engaged with them, talk a little bit more about them. We also sort of look at what their risk score is in Care Navigator to see what that teaches us. And then out of that process, we identify sort of their initial team members and who is going to be the initial lead care coordinator to reach out and engage the patient in the rest of the shared care process, into which we are weaving some of the processes and tools that Care Navigator is going to be asking us to complete. you know, we're really looking at people who, so how do we identify our initial patients? Really, we wanted to see people who had, you know, at least one, at least 2, 3 or more community collaborators. And by confining that to just that one region, our partners like the VNA and Howard and CVAA, they also have regional staff who focus on these other regions. So we were able to identify, okay, if we're going to kind of segment down to these couple of practices, those are the team members from those organizations that we need to onboard, you know, and we're also asking the team, you know, who else do you frequently work with that we may need to bring on with the training process. In terms of the sort of identification related to risk scores, we're really just kind of learning what this process teaches us. We have patients that have a risk score. I think our highest person that we've identified for engagement has a risk score of 35. We also have been seeing patients that have risk scores of, say, 2, 3, 7, 15. So we're kind of learning what these patients look like, and hopefully that will inform us going forward about sort of how we do eventually land around what risk scores we're going to, you know, what people need to be involved with patients of what risk scores. So that's a very quick snapshot. We have, you know, our community health team and most of our collaborating agencies that engaged in this process. It can be a little bit choppy in the sense that we don't have full engagement yet from everybody that needs to be engaged, but we're really just continuing with the process and the conversations to try to bring everybody to the table so that we can have a really good trial with using the tool. It's an evolution in this health service area. Are there, Maura, anything you'd like me to add or particular questions you have?
Well, your process for identifying the lead care coordinator?
Mm-hmm. That really is that happens through conversation at that monthly meeting when we're talking about patients as an interagency team. And that, you know, is someone who really knows the patient well. They either have worked with the person in the past or have a relationship that very often is a SASH coordinator maybe who's working with the patient in their housing setting where we have some integration of their social needs and their health needs. So that's identified through that interagency process at this point.
Great.
So we did get a couple of questions in. The first, I think, would be for Maura. So the question is, will you be showing the Care Navigator tool, walking us through how it is looking at the present time?
Sure. First of all, I want to thank you, Robin, for what you shared. And I'll talk a little bit about the trainings at this time. Do you mind flipping to the next slide up in the queue so I can talk about the training? So we used to do showing the tool in demos, and we've kind of made this more structured. So we do have something called an Intro to Care Navigator training, and it's a WebEx. And within that training, you'll see a demo of the tool. So we won't be showing that today, but I can send out a list of the trainings that we have, if that would be helpful to Catherine. I can go ahead and send that out. And then, you know, just continuing on this, that there's a new user 1 training where people actually get access to the tool, and there's no PHI in that tool, so they can go and play around in it and see what it's like to use it. And then the Care Navigator user training 2 is where you get access to the live environment and have access to patients and can start working with those patients within the tool. So that's
yeah. So we've got a couple more questions. I'm just going to take this one quickly. I can't see it now, but I think someone did ask if the slides were uploaded. Yeah. So will you be able to share these slides? So if you look in your webinar control panel, there's a pane titled Handouts. Click on the plus button and you'll get that, that box will pop up and you can see a PDF right in there. Just click on it and it'll download it and you can save it on your computer. So those are the slides for today's webinar. Oops, sorry.
And you can also tell people about the Intro to Care Navigator trainings. Anybody can attend those. They don't have to be One Care Vermont participants. Really, they're open to anybody. The only training that isn't open to anybody is the Care Navigator User 2 training, because you can't have access to PHI unless you're a One Care participant and are connected with a practice or a collaborator organization.
Okay, so finally, question, how have each of these communities dealt with getting permission to talk about these patients in a group setting? I'm guessing that not every agency who is in the room is supporting every patient that is on the list. So, Maura, maybe you want to kick that off?
Sure, and this really is a whole topic unto itself, so I'm not going to go into it a lot. I did talk about that, how in an ACO it's a totally different structure because ACOs are built to have coordination of care and break down those silos of individuals. You can communicate about patients. The thing that you do need to be aware of is if people are in the room who are not connected to One Care, that's where you need to be aware of that, but you can discuss the patients, and we have addressed that in each of the communities that we go into, but I think there'll be more discussion on that.
Great, I think that's all our questions for now, so shall we keep going?
Great, and sure, so this next slide is up because we wanted to kind of segue into a community-specific workflow, and we took the box diagram and kind of started some work in that, how that would look with integrating Care Navigator into it. So I'm sure there'll be changes to this, but I wanted to start the discussion with something that's familiar. So as we know, people will be assigned patients and start working in the tool, and they say, well, what's next? You know, what happens now once I'm assigned a patient? So that is the next part of ours. If you could just skip forward to the next slide, is looking at a community-specific workflow, because it will be different in different communities. Just as in the box diagram, things are done at different parts of the process, a community-specific workflow will be different to that community. So Heather is going to speak about that because her community is really at that process where you're looking at what do we do next. So if you could just introduce yourself. And
great. Thank you, Maura. So I'm Heather Colangelo, representing the Berlin or Central Vermont group. A little bit different than the other groups, I actually represent the local designated agency. So I'm the Director of Quality Assurance at Washington County Mental Health Services. So I will go over our initial workflow. I'll stay on the slide at least for now, though. So we've really taken Care Navigator and integrated it into our learning collaborative. So this is another tool that we're using in our collaborative. So we've definitely followed the workflow that you saw on the previous screen, but of course have made it our own, but with the same kind of criteria. So how has our participation in Learning Collaborative informed our steps? So again, we're really integrating it. One of the things that we learned is that we've changed our criteria a little bit for locating patients. Learning Collaborative, we really focused on the most complex cases, the patients with the most complex needs, high utilizers of services, and we've expanded more now that we have the Care Navigator, and we're really focusing on those risk scores and those that would really benefit from the collaborative process. Again, so the integration, our membership has not changed. We have 11 agencies around the table. We even still have a representative from our local fairly qualified health center that still attends, even though their group is represented by CHAC. So we still have interest, and we still have people around the table that might not necessarily have vested interest with a patient at the moment, but are still involved in this collaborative process and understand that the healthcare reforms are changing, and there's some changes coming down the loop. So I will flip to the next one here. So hopefully you'll see our differences. I think you'll notice as we go along, this is our workflow. As complicated as it looks, it really isn't. But I think you'll notice as we go along that we really highlight the goals of the software. So the first process is, as a group, we consider the current caseloads that we have, see who is attributed and what their risk scores are. So again, we're not reinventing the wheel. We're really looking at the caseloads that we are familiar with and see who is likely to benefit from these collaborative efforts. One of the things that we did implement that was a little bit different, as Maura stated, if you're attributed, we don't need that separate release form, but our designated agency has requested that those particular individuals really make it clear that they understand that there will be mental health information that will be included into Care Navigator. So we have created a separate release form for the designated agencies, or agency, excuse me, there's only one in that area. So because we integrated it with Learning Collaborative, we asked the question, is care coordination already in place for this patient? So if the answer is yes, then we're introducing the Care Navigator to the patient and to the team members to make sure everybody is aware of this new tool, and then completing the initial assessments. Again, the patient will already have a lead care coordinator, so that's going to be their job. And then the lead care coordinator is going to enter the care plan into Care Navigator, and we're going to continue to communicate as we were. If the patient does not have care coordination already in place, at this point, the care coordinator supervisor will assign a preliminary lead care coordinator, and we use that word kind of in quotes. We don't like to say necessarily lead care coordinator at this point because we don't have the appropriate information needed to truly say, is this the right person for this care? So we're really going on what we know about the patient and the care. Appropriateness really means where the patient's at, what they need, and the workflow, who's appropriate to be starting this process with this patient. The next step is that the lead care coordinator is now going to introduce Care Navigator and use EcoMap to identify the patient priorities and the team members. At this point, we're going to bring in the team members, inviting them to Care Navigator. We're going to be doing some training. So again, we're integrating the training process as we go here. That might happen at a different stage. And then we're going into the lead care coordinator signs candidate cards, and then the two assessments that we have here. At this point, in Central Vermont, we really make these efforts collaborative efforts. So we do have a lead care coordinator who's responsible for doing these, but we really do work together, and there's a lot of delegation that happens with regards to the tools themselves. So there are opportunities when another team member it might be more appropriate for them to use a particular tool with a patient, and so that's what happens. So we're really kind of flow based on the patient's needs. So these are definitely not set in stone boxes here. At this point, we have more information on the patient. We've completed the initial assessment. So now we can really ask ourselves, does the patient, would it make more sense to have a different lead care coordinator in place? And does the patient desire a new lead care coordinator? In Central Vermont, we do not assign the official lead care coordinator. The patient is the one who assigns their lead care coordinator. And it's a discussion. Every step of the way is a discussion. And so at this point, we ask if they need somebody new, if it makes more sense to have somebody else leading this team. And if it is, then we assign a new lead care coordinator based on their needs and their goals. If not, same flow. The lead care coordinator is going to convene the care team. We're going to review the findings from the tools. So we're on our third goal of the software, which is convening and communicating. We'll review our findings, complete a chart review and a root cause analysis. Moving on to hold a huddle, which is a pre-conference to an official shared care plan with the patient. Our groups are finding that there are occasions when these meetings do happen without the patient. And again, looking at the goals of the software, we're on the fourth one, which is to complete a shared care plan, which is the next step. And then the lead care coordinator enters this into Care Navigator, and we set our tasks to meet our goals, short-term and long-term goals. And then it's always to repeat the steps and interventions as needed. So the tools really just are ways to communicate and just learn more about your patients. And one of the things that is not in this flow is the fact that Central Vermont, we do a lot of trainings. It's really, the Learning Collaborative and the integrative healthcare initiatives are really popular, especially to Washington County Mental Health Services, which I can brag about because that's my agency. But we do a lot of trainings. I just spoke at our CRT case management meeting. Their director is really impressed with this and actually has asked that we assist their case managers to have one patient assigned to each case manager. So they have about 20 case managers, so there's going to be at least one patient initially assigned to each case manager. And my assumption is that they're going to really enjoy this process and going to want to have more of their patients be involved in collaborative care. We speak at the community health team as well. So the trainings, as Maura said, are open, so we definitely have some people that are going to be not necessarily part of this process, but wanting to get this information on the Care Navigator. So far, it's been a very smooth process for us in Central Vermont. That's a little bit about how we work. Thank you very much.
Thanks, Heather. And I think with Heather being in the designated agency and taking a lead in the Learning Collaborative, she's run into some different things. And I always say that to her, that what you're running into is different because you're with the designated agency and it's a different view. And I think in each of these communities, there's been really neat things to learn and just people doing things differently, yet kind of running into some of the same things. So I think it was a really good mix of communities to present to you, and I hope that people do reach out to these individuals as they're starting the work in their community. So we did have the workflow. If you want to go to the next slide, we can kind of talk a little bit about next steps. So, we did have that workflow that was initially, and we haven't, the communities haven't gotten all the way through the proposed workflow, so we've kind of stopped there. We do have a question. Do you want to go ahead and read that?
Sure, yes. So the question is, how do you get agencies involved who do not have any risk at this time with the ACO?
Sure. That's a great question. So if someone isn't a medical provider, we talked about that collaborator agreement. So we are working with like Agency of Human Services on a collaborator agreement. So those agencies, any collaborator doesn't hold risk with the ACO. That's what puts them in that collaborator group. So, so we do have a process where you can email me or the Operations Help Desk about an organization that you believe works with patients and that you would like to tie into the ACO. And we have a process where we review that organization and then we talk with them and have them sign an agreement. It's almost like a BAA so that we can then share data with them. So there's a whole process in place. And at the end of this, there will be my email, so you can go ahead and email me if you want to talk about that specific organization. Okay, so as far as next steps, as part of the Learning Collaborative is always giving some pre-work. So we talk about, as you look at the Care Navigator rollout, think about how you can complete this information or start the work in your community. So identifying that initial community leadership team and a core team in your community. As we talk about, is not having a separate team, but integrating it into the existing initiatives, because we know we have small communities, and it's the same people in many of the meetings. So this isn't asking you to recreate something, it's just adding something in to the mix of what's already happening. And look at your process that's in place for identifying lead care coordinators and working to define a process for identifying the care navigator roles, care coordinators, care coordination supervisors, and the care coordination supervisor of One Care Vermont. Again, that person who has access to all patients. And that access is not given lightly. That has to be run through a process, and there can only be a certain number of those care coordination supervisors, One Care Vermont, that have access to all patients. Identifying initial people who will receive care coordination services to include in the pilot from your list. So we have in there Randolph, Springfield, and St. J. Right now, you don't have patients in Care Navigator, so we'll need to work with you guys to look at when those patients come into Care Navigator. And as we know, with contracts and everything and sharing data, things can take a little while. So at first I was hearing in January that the attributed patients from CHAC and Health First would go into Care Navigator, and then I heard the first quarter, and now I'm saying here in the first part of the year. So I think it's going to be a little variable. So we're having to be flexible in those time frames, but we'll work with those communities. And then starting to look at how would a community-specific workflow work for you, and integrating that process into your current learning collaborative process. Okay. So, and attending the December in-person learning session. So with that, I think do you want to talk about the learning sessions in December?
I am going to pause briefly for one more question that came in. So the question, maybe this is more of a comment, field services directors will be a good connection at the district level for any agency of human services collaboration.
Yeah, that's a really good point, because those are the people who know the resources in their community, and I think some are involved, and we do need to work at multiple levels as we look at this. So at this time we are working on that collaborator agreement with AHS, and then I think that will open up more integration. But yes, thank you for that point.
Great. So I just want to offer a very brief reminder that our next all-day in-person learning sessions will be held on December 15th at the Vermont Veterans Home in Bennington, and December 16th at the Department of Vermont Health Access in Williston. And registration links for that event will be distributed shortly. We will continue a discussion of Care Navigator implementation at that event, and we'll get more information out to all of you shortly. So if you have any questions about those events in the meantime, you can contact Jennifer Lee, whose email address is right here on this slide. And as Maura noted, this final slide just includes the email addresses of all of your presenters for today's webinar. I think that brings us to our time today. As a final reminder, if you haven't already, go into the handouts pane in your control panel, click on the plus button, and you'll see a PDF of the slides from today's presentation that'll have contact information and all of that right in it for you. So thank you for your participation, and that concludes today's webinar.
Thank you.
Thanks, everyone.
Thanks for all to the presenters. Brave communities.